Wow, what another great episode we had with Dr. David Rosensweet. We talked about so much. We already had an episode with him, and this is the second episode we're doing. We talked about the best delivery methods of HRT. When you start this hormone journey, you're so lost. You don't know what you should do, pellets or gel or creams or oral. And then we talked about, is estrogen really that bad? We always demonize that oral estrogen. I'm talking about oral estrogen. We know estrogen is really good, but we always focusing on our attention on this. Don't take oral estrogen. He's going to surprise you with what he said. And then we covered what's really inside those gels and creams that you're rubbing on yourself. You want to take a look what's inside, and not sure you're going to be happy with what you're finding and how to mitigate anything that you're not so happy with seeing in them. And then we talked about how to find a menopause doctor, which is so important that you have someone guide you on this journey. And we talked about when to start hormone therapy if you're going to do it, and what is this quote unquote window of opportunity? When is it too late? When should you start? We'll cover all of these questions. And before I introduce Dr. David Rosensweet, I want to just give a little housekeeping here. If you haven't yet joined the Biohacking Menopause membership group, do it today. You won't regret it. The May guests have been amazing. We have live Q&As with guest experts in their field of hormones, menopause, and biohacking. And what you have left in May is Karen Martell. She's incredible. She loves to help women going through this menopause transition. She's a good person, somebody with integrity, somebody I love and trust. You want to meet her. These live Q&A sessions that we have are for you. There's no presentation. You don't have to listen to a bunch of stuff. You just come with your questions. You say, I want to know about hormone therapy. I want to know about biological age test kits. I want to know if ice bathing is good or bad for me. Lots of opportunity to answer your questions. My guests, they normally ask for hundreds of dollars per hour for their time, and here we have it for free. So go and join now. The June live Q&A guests, we're going to have Kristen Weitzel. She is an expert in cold therapy and breath work. She's amazing. She focused on women and women's health. You're going to love her. We've got Leslie Kenny from Oxford HealthSpan talking about spermidine and answer all those questions and how it's manufactured and how to choose a good supplement or how to activate autophagy without supplements. Lots of cool stuff coming on. Deanna Minnick, Dr. Deanna Minnick, she's amazing. She's going to tell us all about melatonin as an antioxidant, and it's more than just sleep. And Faraz Khan, and he's an anti-aging expert, and he knows everything about hair and skin and how to biohack it. He's the host of the podcast, Anti-Aging Hacks, and you're going to love him too. And of course, you have live Q&As with me where I share all of my secrets and tips to biohacking menopause, and I give you breathwork sessions every month as well. So that's what's coming up in May and June in the Biohacking Menopause group and Hack My Age. And then another interesting thing that you may want to attend, some couple of events that I'm going to be going to in June. We've got the Health Optimization Summit. That's like the biggest health summit in Europe, and you want to go there. It's a lot of biohacking going on there. They don't advertise it as a biohacking summit, but there's a lot of stuff going on in there. That's on June 15th to 16th. I've got a link in the show notes. I don't have a code. I'm not affiliated with them, but I'm going myself, and I'll get you one. If you need it, just message me. I can find one for you. And then I'm also going to the Oxford Longevity Project's annual summit called Smart Aging Summit. That's on June 29th. And that's in London. And sorry, that's in Oxford. The Health Optimization Summit is in London. I can't remember if I mentioned that. So you're going to have to fly to London, meet me there. I'd be so happy to see you. And then I'm also going to be in June 29th in Oxford, in the UK, and that's for the summit. And I'm going to be leading some breathwork classes alongside Kristen Weitzel, my breathwork and ice bathing buddy. And there'll be Dr. Sandra Kaufman, who we also interviewed on the podcast too, and Leslie Kenny will be there, and spermidine, and so many cool things at this event. And I hope you can go. I'll have a link to that in the show notes. I don't think there's any discount codes, but I'll Find one if you want one. Just text me or somehow find me on Facebook or Instagram or email me. Now let's get on with Dr. David Rosensweet. We had a first episode, which I'll have the link into the show notes, and we started talking and we just ran out of time, just like we did in this episode. It was just so many questions. And we're bringing you a part 2, and we're going to have to bring you a part 3 because we didn't finish all my questions. And in our first episode, we had a 3-way with Dr. David Rosensweet and Jill Chmielewski, who she was a great mediator in that first introduction, introducing you to Dr. David Rosensweet and how much he knows about menopause. And he's been treating women with menopause for over 30 years. He's a medical doctor, and I I get a lot of backlash when I share reels or information from a man. Ladies, let's like have some trust in the guys that I'm introducing you to. Let them speak about menopause and medicine or women's health. I've chosen them because they know a lot and I trust them. So that's why I had Jill Chmielewski on the episode to try to balance that out. And now I've interviewed her separately because she's fabulous too. And we're gonna have so many more episodes with both of them. Now, back to Dr. Rosensweet. He's the founder of the Institute of Bioidentical Medicine and the Menopause Method program, which by now you've probably all heard about because this is the program that I went through and I'm always raving about. I learned so much. I already knew a lot, and boy, I learned so much more. And if you're a health practitioner who needs to learn how to prescribe hormones for menopause, go check out the Menopause Method at iobim.org. Tell them Zora sent you. You're going to get a 10% discount too. And if you just want to learn more about hormones for menopause, you can still get in touch with them and see if you qualify. It's amazing. Dr. Rosensweet, he also wrote 3 books on the subject of hormones. So he's really qualified about this and menopause. And his latest one is Happy Healthy Hormones. And we have that for free in the show notes. So go and grab that. And you may have seen him speak already if you're on this health and menopause circuit, because he travels the world, lectures on the topic of hormones and functional medicine. He's a pioneer in this field, and he was one of the first doctors who trained the first nurse practitioners in the US, and he was in charge of health promotion for the state of New Mexico. And now Dr. Rosensweet spends most of his time as the medical director of the Institute of Bioidentical Medicine, where he trains medical practitioners to specialize in menopause and andropause medicine. That means men's hormones, because they go through their own little menopause journey, just not the same as ours. And we really need more people like him. He has a lot of work ahead of him, and he's just fighting for women's health and hormones. He can retire. He doesn't need to work another day in his life. And here he is sharing his knowledge, training the doctors, trying to get the message out there. He's unbelievable. So I really hope you enjoy this episode. So without further ado, now let's meet Dr. David Rosensweet. Welcome.
Thank you, Zora. Good to be with you again.
Yeah, we still have so much to cover. In that last episode that we did, we talked about what exactly is hormone replacement therapy, HRT, what is MHT, we get the different names, and menopause hormone therapy. And you also went into detail on the benefits versus the risks of taking and not taking hormone therapy. And you explained why women and doctors are scared of estrogen and how this is changing. And we covered the different attitudes towards menopause that women have. We covered a lot. So if you guys want to listen to that episode, I'll have that in the show notes. Go check that one out for sure. But today, I want to take a deeper dive into some of the confusion I see in our biohacking menopause community and Hack My Age community. And when a woman starts to investigate hormones and then trying to figure it out and understand it, she's bombarded by a dozen delivery methods. You know, there's just so much out there. There's creams and gels and pills and oils and pellets and injectables. Like the list goes on and on. It's so overwhelming and we're so lost. I remember when I first got into this space going, what do I do? So let's cover what's out there and which ones that you're seeing in your practice for the last 3 decades or so to be the most reliable and the most safe and the most effective. What are you seeing?
I mean, as far as treatment of women in menopause,
For treatment of women in menopause, for sure. When she
what's
just
the most
what the
reliable
deliver
and
there's delivery methods. Like there's some people who
yeah,
are anti-pellets. There are some who prefer the transdermals, others who get the orals. And
yeah, I
we
get
should
it.
cover
Yeah.
what's out there. How can a woman decide what is the best one for her?
Well, one of the things that I've done is I've taken a great deal of care to write this into our book, Happy Healthy Hormones, which your audience can download a free PDF copy of this book. And what my intention was there is to describe to a woman what I consider to be the absolute optimal approach. What is the state of the art? What is standard of care? That's what I've laid down. And we just finished the eighth edition like 2 weeks ago.
Oh, wow. So
Yeah.
I'll have the link to that in the show notes, but does the same link go to the eighth edition?
It
The
goes to
new
the eighth
directly.
edition,
Okay,
goes to the brand new edition.
cool.
And what I think is the very best thing is number one, a principle of you go to a provider, a physician, a nurse practitioner, or a PA or prescribing compounding pharmacist that really loves this field and really has taken on the effort it takes to really get an education in it because the body of knowledge around hormones happens to be very big, but it was nothing any of us were taught in our basic training, like medical school, for example. So you have to really reach out and go after the training. And so if you find someone who you like and you can communicate with and really cares about and loves the field, you're gonna get a decent, you're gonna have a good time. And you're going to wind up with a system that's going to serve you usually for your whole life. One of the principles we want that provider to abide by is individualization. You know, there's such wide variation between one woman and another. Same goes for men, but we're talking about women here. Um, we just are individual. Like one woman may need this much hormones to be young and fertile and regularly menstruate, whereas another woman may need 3 times as much. And both of them are healthy. And then there's everyone in between. Well, it's not a problem. Any provider that really has dived into this is going to individualize their therapy with you. And it's a process, If you're in perimenopause, that means for the last 10 years, minimal, you've been in a hormonal decline. And it's a process to readjust to also receiving hormones from the outside, those that your ovary are contributing, plus the replenishing to get you up to reasonable levels. If you're in menopause, you haven't had any hormones for 6 months or 6 years. It's a process that we consider to take place anywhere from 2 to 6 months to really get your body to readjust and really stabilize at lovely levels. So the provider that you're going to work with, you want to realize it's a process and they know how to guide you into individualization. That's another key point. Now I want to give you my best shot. The optimal way to deliver estrogen is through an organic oil base topically to the skin. There are other methods. There are creams and gels, for example, but estrogen should be topical. We learned this with the birth control pill. There was a rare but definite a number of women when they took oral estrogen in the birth control pill, they got thrombophlebitis, a clot in their leg. And some of those women went on to that clot traveled to their lungs, which is a little life-threatening. So even though it's rare, there's reasons why that oral estrogen does that, where topical estrogen does not do that, does not promote coagulation. So you want your provider to be giving you a topical estrogen. And look what I'm leaving out here. I'm leaving out injections, I'm leaving out pellets. we have some real challenges with those systems. That will be for another day. I want to give you my best shot. Topical estrogen. Same for testosterone. Testosterone in a woman, women need to understand, and I apologize if I've covered some of this in
No,
our
no, we need,
previous
yeah, we we need to repeat it. Even if we did, we need to repeat it.
yeah, testosterone. A young woman's body produces twice as much testosterone out of her ovary than it does estradiol, the most potent estrogen. It is
Amazing.
not a male hormone, it is a human hormone. And testosterone is so important for the long run. I mean, what gets women into assisted living facilities and nursing homes? We have estimates, someone on our medical board is an expert in treating patients in nursing homes and assisted living facilities. That's one of the things she's done in her previous iteration of her career. And her guess is 80 to 85% of women are there because of loss of muscle. It's well known. And in order to maintain your muscle for almost every single woman, you need your beloved testosterone.
Yeah.
And so that's one of the greatest services we do for women. And the safest way to administer testosterone is topically.
Hmm.
That means you apply it to the skin and it absorbs beautifully. And, I'm a big proponent of how delivering it in an organic oil base. There are other ways. There's creams and gels. They've been going on for 40, 50 years, dispensing hormones in this way. But I want to give you the state of the art. These creams and gels are solvents. And, 95, 98% of what's in a jar, a toppy click, or whatever method you're using to dispense it, is the solvent. So daily application of solvents is not a good strategy. So we've developed and patented a certified organic oil. Certified organic oil, good for the skin. So
Yeah.
that's what we recommend for testosterone. My favorite way to administer progesterone is also topically in the organic oil. And some women are going to do better with oral form of progesterone. Regardless, it's a discovery process. For example, you have a woman who has low progesterone symptoms. She's not sleeping well, she's got anxiety, even young women. So you start with a lowish dose of progesterone and you gradually increase until the woman said, wow, my anxiety is gone and I'm sleeping well. That's the process.
Yeah.
It's dose determination by alleviation of symptoms of insufficiency while falling shy of or backing down from symptoms of excess if you go too high. These hormones are so powerful that in most cases, you take too much of one of these hormones, you're going to get symptoms.
Yeah.
So you
Other
want,
symptoms that you maybe didn't expect. And that's a very important. I love how you taught us how to self-titrate in the Menopause Method programs, which I'm talking about, Institute of Bioidentical Medicine. You're training doctors and health practitioners how to approach their patients, but also teaching the doctors to teach their patients how to find their optimal dose. And I found that amazing. And that's never happened to me with any of my other doctors. And I wish they did, because I would have one meeting a year because it's very expensive and my healthcare doesn't cover this. So once a year, I see the doctor, take the hormones, and then the next year, and because I'm asymptomatic, I don't know if they're working or not working. And then eventually I get to a point 3 years later, I take a bone density scan and I've had osteopenia because I didn't have the symptoms and no one was checking me. And so this is where we want to alleviate symptoms. And I'm glad you covered that. But I also love that you are teaching doctors to also protect our future selves. Look, and how can we get the dosage right so that we help that woman as she ages? It's longevity after menopause, and that is so important to me, and I think to every woman listening out here. So thank you for doing that, including that in the program, and I highly recommend anyone to go do this program because you will learn so much, and I have links to that on the show notes too.
and there is something you just brought up that is really important. Like when you go into traditional teaching, on how to treat a woman in menopause, they say just give a woman this dose and there's no need to test them because testing doesn't work. And what they're referring to is salivary testing, and I'm a proponent of not salivary testing for ovarian hormones, maybe for adrenal hormones, but not ovarian hormones. And they know that blood test doesn't work because it depends on when the woman took her last dose. Let's say she took her bias in the morning at 7 o'clock after she showered, or at 9 o'clock, and then went and got her blood drawn in the afternoon or at noon. Or when do you get the blood drawn? So there's issues there. But what they didn't include was the gold standard since the late 60s, which is the 24-hour urine hormone test. It is great. It is fabulous. And it's the gold standard of testing. And I'm not talking about other types of urine procurement, like paper, peeing on filter paper. Now, our method is our project includes cross-testing these. That means splitting a sample. So we send off to many different labs from a single woman doing a single day. So we're in the process of gathering data on this, but right now you want to choose a provider who really is devoted to this 24-hour urine hormone collection, 24-hour urine hormone collection, not 5 different collections, 24-hour. And
That's
because here's part of the issue. If a woman takes hormones and gets her symptoms alleviated, that's fabulous. That's a great thing. But I once did a study of 51 of the women in the preceding year that I had done 24-hour urine hormone testing on that said, I feel great. I found my dose. Well, that's the time we want to test them. And what I learned was that 50% of those women, even though their symptoms were totally alleviated, didn't have sufficient estrogen to protect their bones in their vagina. That's the bottom line. And that's why many women learn years later, oh my God, I got a bone density and I had osteopenia. I had some bone loss there. 50%.
yeah.
And then 25% were on dosages of estrogen, for example, a little too robust that put them at risk for breast glandular cell proliferation, just like a younger woman does every single month. She gets breast glandular proliferation. So 25% were on a little bit too much.
Yeah.
It doesn't mean that we don't go higher on some women to protect their brain, the ones who really need robust dosage, but we want to know what we're doing there. And so capping off a process where we don't test women's hormones in the beginning, there's no reason to do that. We do test them about the 3 month mark when they say, wow, I feel better. Okay,
Mhm.
now we want to confirm that you don't have too little and you don't have too much.
Yeah.
So those are the kind of things to look for. And then it's good to replenish DHEA as well. We combine it with testosterone, makes it easy.
Hmm.
And there's some of the, I've sort of lost sight of the original question is what
Yeah.
would you recommend to a woman?
Yes.
Find a good provider, choose someone who really cares about it, is really specializing in it is the best.
Yeah. Let's talk about then how to find the provider, because this is a question I get all the time. I have a resources list on my website, how to find a menopause doctor, and included there is iobim.org. Reach out, find somebody who is trained with the Menopause Method by Dr. David Rosensweet. How would you recommend a woman? Perhaps there's women in Europe or Asia who I don't know if they can find one of your trained doctors. What would you recommend them to do? And when they approach their doctor, there are questions they should be asking to make sure that they are confident with the type of treatment that they're going to get.
Well, this is the bottom line question. This is the most important question. How do I find someone? And I must say, I have a strong preference that they find someone trained by us, and that yes, and we're training more and more people all the time. We're almost all 50 states right now. So iobim.org and download our book. And if you like the method, go to iobim.org and someone on our staff will direct you towards someone. Another way to do it in the United States and this probably pertains to Europe and Australia and Asia, is you're going to want to wind up with compounded bioidentical hormones. So depending on the country you're in, you're going to want to find a compounding pharmacist. Like in the UK, for example, or Australia, there are compounding pharmacists. These are the pharmacists that make up these highly individualized prescriptions. They've got the pure hormone and they're following the prescription of the provider and they make them up in creams and gels. And we're working on getting the oils to Europe and Australia. But if you go to one of these compounding pharmacists, you find one and go in person because these are busy folks and calling them on the phone isn't going to cut it. Walk into that pharmacy if you can and ask to talk to the compounding pharmacist. And they're usually very friendly people that like dealing with patients. That's why they've chosen the lane they have. And ask them, I want to be treated in menopause. Who's your favorite person who's writing you prescriptions? Give me the top three, would you please?
That's a good one. That's a good one. I've got
Yeah.
a lady in Nigeria who says it's very hard to get uh, hormones in general there. So this will be a tactic. If anyone listening has a doctor in Nigeria, please contact me. We want to help this poor woman who desperately wants to start hormone therapy. But that's a
And
great idea to go to
yeah,
the compounding
that's one
pharmacist.
of the best because they know they're receiving prescriptions from all kinds of doctors, nurse practitioners, and stuff, and they can tell by the quality of the prescription who's doing the best work. And they
Yeah.
often are talking to these people because they're extremely knowledgeable, most of them. They've been dispensing hormones for a long time. And when they see a prescription that comes in and goes, wow, this person's pretty accurate here, they know what they're doing.
Mm,
They know these people.
yeah.
I would recommend that anywhere in the United States, all over the world, do that. There's another resource. If you start talking to women in your area, it's likely that you're going to run into someone who's on these hormones. And you want to contact her and you want to ask her, who are you seeing? Do you like them?
Hmm.
Network. And I think this could be a new value of social media that someone could gather, ask women like Zora. I don't know. You and I have never spoken about this. Maybe you've already done this, but you ask your audience if you have a provider that you really like, that you feel is doing really good work, and you're feeling great, and you've been tested. Send us the name. We'll develop a map of the world, and we'll put little pins in with names. Use social media to bring out of the woodwork these people who are doing really good work.
Yeah, that actually it was a good. This is working. The one of the most recent posts I did was just I asked women a question: where are you in the world, and how much do you pay per month for your menopause hormone therapy? That's all I asked. Just put your emoji flag or whatever. And there was a lot. I woke up to 200 comments. Now there's over 300 comments, and I was reading the comments and women are connecting. They're saying they're in Australia, they're paying for $25. And then the other one says, well, there's some woman comes on and says, well, I'm spending much more. Where are you getting these hormones and who's your doctor? And it was so beautiful to see this support and this connection with among these women helping each other because they could identify each other by country and then ask their questions and try to get some leads for what it is that they wanted. So you're absolutely right. It's social media is a very good tool. And I really hope that women, and I like that you said, just talk to your friends. And that's what we're trying to do here at Hack My Age is to make the menopause discussion normalized. Like it's okay to talk about this in many countries and other cultures where I go and interview women around the world. It's still taboo. They still don't want to talk about it, or you don't talk about it. It's just not their thing. So they've been raised like this. So I really encourage women to reach out and don't be shy because if you're speaking to a woman, she'll either be in menopause or is going to go through it or is going through it right now. So that's a really great tool, and you can post this stuff as well. So my next question, I want to go back to you started to talk about your preferred methods of delivery, and that was you said organic oils. And And I really was amazed through the menopause method that you taught us about the ingredients that we find in our hormone creams and gels. And then you just went on to say it was somewhere between 95 to 98% of what we rub on our skin is the actual solvent or carrier. And only 3%, more or less, is the actual hormones. And most of us in this health and wellness space, we've already taken action on getting the toxic body lotion out of our life and we buy fragrance-free shampoos, but we never think twice about what our hormone gels and creams are actually made of. And we're rubbing it on our bodies every single day, sometimes twice a day. And I would love for you to explain why we do need to take a look at the ingredient lists of what's in our creams or gels or oils and just share a little bit more what we learned in the menopause method.
Well, to back up just a little bit, for 1,000 years, women have been treated in menopause with all kinds of hormones. And since the 1940s, by the year 2000, 18 million American women were on hormones. By the early 2000s, 40% of those in menopause, because they've been around for a long time. Those 18 million women were on something called Premarin and Prempro. They were oral estrogens and a progestin molecule. And these women did better than the other women. And I had many women patients over the years who came to me. They were very happy with their Premarin and Prempro, but they had heard about bioidenticals. They wanted to try it out. Now, I've never written a prescription for Premarin or Prempro, but I want to let you know that these hormones are so important that if you can get them, you're going to do well. But then it's, well, what do you really want? Well, you're going to really want excellence in medicine. And so almost anyone dispensed by a provider that really cares is going to get decent treatment, no matter what the method. And yet you're probably going to want the state of the art, the cleanest and purest. And I think I told this story the first time out, but interrupt me if I did. I had been prescribing hormones and gels for a decade. And I wrote a prescription to my pharmacist, and he shipped it directly to the patient. And I had never seen a hormone. I'd been doing this for 10 years. And then one day there was a missed shipment. Instead of going to my patient, it came to my office, and there's this white cosmetic jar that had Biest in it. And I was fascinated. I had a chance to look at a hormone. And I cracked the seal and opened it up, and out comes this strong odor. And it was the base. And over 99% of this gel, this hormone in gel, was actually the base. And only less than 1% was the actual biased. If you do the math, and I've done this in the book, you'll see it. Um, but the thing that really caught my attention was the odor. It smelled like some kind of solvent. And then I learned that they had to do this, that the steroid hormones, estrogen, progesterone, testosterone, DHEA, were fat soluble and were very, very poorly soluble. You need strong solvents, not just solvents like water. It wouldn't work at all. And you need something as strong as alcohol, plus or minus, to get them up into solution. Chemistry texts say use formaldehyde. That's a really strong solvent, but no one's using formaldehyde. But they are using a hydroalcoholic gel or some kind of cream as a strong solvent. So I was shocked because I was a functional medicine doc and I had been detoxifying my patients. And I did the math and I realized that I was detoxifying most of my patients and telling them to do just what you said, eliminate all the cosmetics that got any kind of stuff in it. And at the same time, I was asking them to apply, now hear this, 1 quart a year for 10, 20, 30, 40 years. We're talking here,
Yeah.
plus or minus a quart. Well, that's what really inspired my son and I were partners to really reach out. Well, we got to change this. And we went through quite a process in years of testing and discovering and came up with the organic oil base. Now, it's not a solvent.
So
So prior to every time you use it, you have to shake the bottle about that much. That's it.
yeah.
So there is no solvent in there. So if the only tool I had was the gels and creams, I'd embrace them like manna from heaven.
Hmm.
because and in some countries you can't get the organic oils. In fact, we're training people in Australia and the UK, and we don't want to get them concerned because in general, the beauty of getting hormones and the importance of getting hormones so outweighs the delivery system. But what are we aiming for? Well, how good can we get this?
Yeah.
So if all you can get is creams and gels, embrace them like manna from heaven. My God, our exposures to stuff, chemicals and stuff, is so outrageous. And the benefits of these hormones are so wonderful for us and so important. So embrace with good heart. I can't lead a pure life. I've been organic for about 50 years,
Wow.
but I travel and I can't get the level of perfection that my brain says we should know. We're humans. This is not a perfect world. So I say what you can get, embrace it. Read our
Yeah.
book, whatever method you got access to, our book will help you dial in a good dose for yourself and you're going to do great. So, in the context of we want the very best, good enough can be really beneficial. And so
That's
you
true.
look at your local resources, you accept it like I had a German patient who had breast cancer and she came to me. She was 5 years out, and the reason she came to me was that she wanted to learn is there anything else she could do for her health to protect herself for the rest of her life. And she described when she had the cancer that she was in Germany and she was given a bunch of options and she took the chemotherapy route and radiation and surgery. She needed all three. And she said to me, when I was receiving that chemo, I embraced it like it was manna from heaven. Those were her words. That's where I got that phrase. And here she is sitting in front of me 5 years after the original diagnosis, and this woman looks so healthy and so great. So I want to put things in perspective. I know patients. I have a family member whose life was saved by chemotherapy. So put it in perspective. A little gel that's like a drop in the ocean of chemotherapy. You choose
Yeah.
the right medicine at the right time. And if I'm giving you a blurry answer, I want women all over the world to be able to get what they got and to be able to receive it, and they'll feel the difference. If someone does a decent job with them, they're going to
Yeah.
feel in it and celebrate the difference of the hormones because they're so powerful. They're the most powerful biochemicals in our body. When we lose them, we'll take a look at people in their hundreds or their 90s or their 80s if you can find them.
Yeah. Yeah, I can't wait until generations pass and then we can do some studies on women who've been on hormones for 20 years or 30 years. And ones who haven't, it'd be interesting to see what conclusions they make. And I agree with you 100% that get whatever you can. That's most important. Get the help and don't have it in your head that, oh my gosh, these are, toxic solvents that I'm rubbing on my body. I think there'd be more damage with the thoughts in the head than the actual toxins. But we are a biohacking community here too. And so we like to optimize and get the Rolls Royce. So if we're going to spend the money, let's like do the best that we can. And if you have a choice, then you go for the organic oils. And so I'm in Europe and I can't get a hold of this. I'm going to be on a mission to talk to a compounding pharmacist to see how close can I get to that. But if I were in the US and I was listening to this and I say I want to get the organic oils, do they just talk to the doctor and say go make compounded with that, or do they talk to you, or how can someone get these organic oils?
Well, for one, if they contact Karina at iobim.org, and she has a long list of providers. And there's a couple ways to do it. We have a national pharmacy, that's the best financial deal. And we have a certain number of prescribers that are going directly to that national pharmacy. Or there's 35 pharmacies in the United States that dispense, so we can cover any state with one of these dispensing pharmacists. And so the real trick is you need a licensed healthcare provider to write the prescription.
Hmm.
And so anyone who's trained in our method can write the prescription to one of 35 local compounders, or best case, because of the pricing, to our national pharmacist. Or to to go at it another way, and we've had many physicians and nurse practitioners come to us this way. If they go to their trusted nurse practitioner or physician and say, "Hey, listen, I'd like to get these hormones in the organic oil," well, we can easily train up their physician to write the prescription to their local pharmacist or to the national pharmacist. We do it all the time.
Mm.
So there's lots of access points there.
What about someone who's in Canada?
We're working on Canada.
Mm,
We
okay.
got, we're working on Canada big time. And
Yeah. There's
uh,
a lot of
both on,
Canadians
both on the
listening to.
providers and the compounding pharmacists, and we're in active contact with a national compounding pharmacy in Canada, and we're working on Australia and the UK.
Mm. One thing I'd like to clear the confusion on, because this is somebody like me who's observing the bioidentical movement, the Women's Health Initiative, and like you said, what's going around social media is the WHI study was false. There were some issues with it. There's some loopholes. It was made headlines. It was sensational headlines. But at the same time, there was there were good things that came out of it too, right? So there were some, like you mentioned, there were women who were on the oral, of course, they were taking oral estrogen, and they did have better outcomes. So how can we, it's like we almost using the argument of the Women's Health Initiative to our own advantage. We can say whatever we want and then back it up. But overall, I mean, what would you say are some of the good things that came out of that study? Because we seem to demonize it all the time.
Well, in the original study, anyone who actually read into the study and didn't get stopped by the press release, which was false, would learn immediately that the women on Premarin, this is horse urine-derived estrogen, had less of a risk of cancer. Like, for example, one of the ways we measure risk for cancer, breast cancer, for example, is it's called relative risk. And a relative risk of 1 means there's no risk. A relative risk of 2 is, there's 2 times a chance that a woman's going to get. Well, the women on Premarin alone had a relative risk of 0.79. That means they had less of a risk of getting breast cancer than women who were not receiving Premarin. That was
And
right
yeah,
there in the original
yeah.
study.
And
Also in that original study, women on Prempro, and this is the thing that blew up, but it blew up falsely, there was a 1.26 relative risk. But right there in the original study, it said, but that is not a statistically significant number. So we know in medicine what that means is don't pay any attention to it. There's no conclusions can be drawn.
yeah.
But that's not what blasted out over the airwaves. Well, the original study committee followed those women, and in following them, they learned by 2006 that the relative risk for Prempro had dropped to 1. And that means there was no increased risk there either.
Yeah.
And the Women's Health Initiative is not a resource to dive in and see the beauty. But even the Women's Health Initiative, which was retracted by the original study committee in the same journal in 2017, they wrote, after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, and stroke. They admitted it, but that did not receive hardly any press. If you go and interview 10,000 physicians and ask them, was the Women's Health Initiative correct? And they'll say, yes, there's increased risk. They didn't hear about the retraction. So I wouldn't hold the Women's Health Initiative as a great resource, but I would hold many other studies as great resources for the preservation of bones, for the preservation, because it's a scourge. It's an epidemic. When a woman loses her hormones, it's almost guaranteed she's going to develop bone loss. And I think I mentioned this the first time out. In 1968, as a senior medical student, we get this lecture in the hospital by a gerontologist. This is a physician who is an expert in treating the elderly. And he said, You senior medical students, you know thousands of diagnoses. Let me tell you what's happening to older people. They're losing their bones and they're losing their muscles. And they get unstable. They move from canes to walkers and they fall and on osteoporotic bones, they fracture their hip and they die. You want to do something for older people, focus on their muscles, their bones, and their brain, because they're also losing that.
Yeah.
And this is 95% of the time, this is all about hormone depletion.
Yeah,
So,
it's true. In my gerontology studies, we did not talk about hormones. We talked it for a split second. And we talked about falls and fractures and fall prevention and learned all about that and try to preserve their bones and their muscles. And but no one said anything about hormones. So I think we need to rewrite some of the curriculum in our gerontology school. And I went to USC, which is one of the top gerontology departments or schools in the nation. So I feel like going back and teaching them a thing or two. But what is interesting though is despite the fact that there was a conclusion of zero risk with oral estrogen, we're all saying don't take oral estrogen, and because of the increased risk of blood clots that I guess we've found, but that was not through the Women's Health Initiative study.
well, they certainly didn't blow that up, but it was common knowledge because of the birth control pill.
Hmm.
And I don't say don't take, you never say never in medicine. Like, think of the millions of young women who are put on oral estrogen. How many developed a blood clot? Very few, but enough that it's reported on the physician's information sheet. Warning, blood clot is possible because it occurred, even though it was a small, well, who got the blood clots? Why were there millions of women given oral estrogen and they never got the blood clot? But some did. Well, these are women who had a special increased propensity to clot. There was some reason, and it just took that extra oomph that oral estrogens are known to do. So what do? We screen for this. Now,
Yeah.
we're not concerned about it because of topical application, but in our questionnaires, we're going to screen for. Did you ever have any trouble on the birth control pill?
Hmm.
Yeah, I got a clot in my leg. We're going to screen for that and see if that increased propensity to clot still exists. Because coagulation is poised. Don't bleed too much, don't clot too easily. Right there in the center. But what we know about American population is there's a skew. It's towards hypercoagulation because of environmental infections and toxicity.
Hmm.
We
Yeah.
are moved towards the propensity to clot. So we want to honor that and pick up on it and prevent it because it's not hard to get someone to move over to the center. My God, you can do it with all kinds of nutritional supplements for most people. And even if you need a medication, you do what you need to do. So, what am I saying here?
What about the oral estrogen? And I asked
Yeah.
because it's like, oh well, if the study says this, then why are we all against it? And then, and of course, it's not as bad as it's I guess as people demonize it to be. That being said, I don't know if you know this. I heard through the grapevine, Dr. Avram Blooming, who wrote the book Estrogen Matters, who I think every woman should read because he debunks this whole Women's Health Initiative study. He prescribes oral estrogen, even despite writing the book on it. So it's like, so that's why it gets confusing. Like, well, is it really that bad?
Well,
That's,
let me address that. There's a lot of opinions. And when Dr. Blooming wrote that book in 2018, I was so blown away by how excellent it was. Here was finally the medical Bible on risk and really pointing out that there wasn't increased risk from the hormones. And I flew out to LA to meet him and I spent time with him. And since have carried on a correspondence with him. And he is a world expert on risk. And he is a world expert to demonstrate that most women do have reduced risk if they're on hormones. And it's phenomenal work. But there's some at the end of our initial conversation, we were at a coffee house and we spent an hour and a half together. And I said, Dr. Blooming, I know you take a stand against compounded bioidenticals. And isn't it fascinating that we're here, you and I are sitting at this table right now, and one of us is absolutely wrong about our stance there. And he laughed and he gave me an explanation that I don't really think is what matters there. For some reason, he's taken this stand, and bless his heart, he's a genius physician that's contributed so much to the health of women on this planet that if we differ on this particular point, it's okay.
Yeah. When we talk about risk and women are so concerned, for me, I just stand back and I say, well, wait a second. Let's look at the risk for breast cancer with being obese, with drinking alcohol, with smoking, with all the other factors. That is a real risk that we seem to ignore, we don't pay attention to. We're so laser focused on something that's pretty much zero. And we forget about all the other things in our life that may increase our risk of whatever disease. And we're just not paying attention to this. And so I really encourage women to really focus on that and try to clean up that side of their life. And then those are real lowering the risks of whatever it is that you're concerned about. So I have one more question because I'm going to have to let you go. And I think this one is a good one to end on. The timing of when to start hormone therapy. Woman listening to this now may be thinking, okay, maybe I should look into this. Menopause societies around the world are saying, they're stating, they can read it online, that a woman should not be treated with hormones if she's 10 years post-menopause or over the age of 60. And so we're under the impression that, like, oh, we better hurry now, otherwise it may be too late. And then there's the woman who is over 60 already, and she feels horrible that she missed this window. Tell us what you think about this window of opportunity.
Fabulous question, as usual. These theories go around, and I'm going to address this theory. But I want to get really up close and personal as I watch my mother and my mother-in-law deteriorate in very special ways that I knew were related to hormones, but my mother would not let me deal with the female part of medicine until she was 86.
Wow.
And I did. And I gave her oral estrogen, no less. The only patient I've ever given oral estrogen to,
Why?
because she was getting cognitively challenged so much that dealing with the topicals was too complex for her. But she could take a pill every day. So the only patient I've ever written for oral estrogen, but you never say never in medicine.
Yeah.
And so for those who have theories, if you have a mother or it's yourself, the whole world changes for you. I'm working diligently. There's a world leader in a specialized support that this couple has given to the planet Earth. Their contribution is so huge, and they're in their 80s. And I'm working to help them realize that to recover enough to continue your good work, it's likely you're going to need some hormones. So sorry to make it complex. The simple answer is this. Whenever you get the idea to do it, whatever age you're at, explore it. Read about it. Go find an expert. They'll know what to do. So now let me cover the full answer to your question. At what age? There are a number of young women in their 20s that have anxiety. But when you look at their life, they're really dealing with the normal challenges of life. What's this word anxiety coming from? They're usually progesterone deficient, or very often progesterone deficient. All you have to do is ask these young women, are your periods clockwork regular? If they're not ovulating and they're not producing enough progesterone, and they're going to develop this mysterious word called anxiety. when they're not getting the normal calming effect of progesterone. So much good can be done for these young women by getting them over the counter topical progesterone in a cream or gel. So much good. And we have world experts on our medical board who know about progesterone, and they talk about this, the number of young women they've treated. So low end, 20s, maybe we'd venture into the teens eventually, but 20s. That's not the common age. The common age is when the symptoms start appearing, midlife, perimenopause, early menopause. Do it. Learn about it, find yourself an expert, do it. Let's take the case of the woman who's 60, hasn't had a period for 10 years, and has never had hormones. Do it. If you find the right provider, they're going to note that. They're going to note, oh my goodness, you're 10 years without hormones. We're going to do a little bit of extra investigation on you to deal with the rare possibility that you're vulnerable to some heart issues. Well, we know how to screen for that. Simple, non-invasive test,
Yeah.
because that's the vulnerability. It's a very unusual quirk. I don't know if you want me to go into the detail, but women who haven't seen hormones for 10 years, although we never rely on the 10-year mark. If a woman has had an aunt with a stroke and a mother who had a heart attack, we're going to say if they've been 3 years or 2 years without hormones, we're going to do the special evaluation of whether they clot too easily, stroke, heart attack, or whether they're vulnerable to arteriosclerosis. These are pretty simple screening tests to do. So before we launch into a hormonal program, we see where they're at. So my answer is, whenever the woman gets the idea, gosh, maybe I should consider hormones, right up into your 80s and 90s, you get that idea, your job is the exact same job we started this all off with. Find a provider who knows this field. They're going to notate that, and they're going to do the necessary screening tests to rule out what happens when you haven't had hormones for a long time. That's
Yeah.
what the window of opportunity is about. And then it gets down to the actual patient. And a really well-trained physician or nurse practitioner or PA is going to zero in on something called risk and benefit. Would my mother go for those screening tests as she had lost a considerable amount of cognition and fell off a cliff when my father passed away at the age of 94? No, she was not going to be going traipsing to get a heart scan or anything like that. So what did I do? I knew enough about her that knew she could walk a mile easily. How compromised could her coronary arteries be? And I haven't gone into what that window of opportunity is. She wouldn't be able to do that if she had compromised coronary arteries. So I took the risk. And of course, she never did develop any coronary So this is the art of medicine that relies on the individual patient and the details.
Yeah. And when we,
Every
yeah.
woman, every single woman, if I'm dealing with a woman who's afraid she's going to have breast cancer, even though I have her read blooming and I educate, I give her and she comes back to me and said, I'm still nervous about it. I said, fine, this isn't an emergency. Let's explore further. My guarantee to you is if you pursue this topic, you're going to know what's right for you, yes or no. So, lots of these questions could all be elaborated on, but the bottom line is whenever you think of it, and your job is the same, find a knowledgeable provider. And they're going to pay attention to the risks and benefits, and they're going to explain them to you. And they're going to do some screening tests that are easy enough to do if you've been 10 years out without hormones.
We have to also remember some of these guidelines are what they would say use the word HRT in general, but what is HRT? There's so many forms of it. There's so many ways to deliver it. There's so many ways to formulate it. So I don't like when people make these sweeping statements of HRT and that's the way it is. It's like, well, what are you talking about? Are you talking about bioidenticals? Are you talking about the compounded? Are you talking about prescribed, oral, transdermal? Like, I hate these blanket statements of HRT, yeah, good, bad, whatever it is. I'd like to know the details because I know that there are big differences in it. So that's just sort of a reminder of people to do a little bit of the homework, some of your due diligence and again, educate yourself. That's the best thing you can do. You're listening to this podcast. If you've gotten to this part already, bravo to you because you are educating yourself and there's so many resources out there. And what I tell every woman when they listen to things, including me, including what Dr. David Rosensweet is saying, be a little skeptical. It's okay. I want you to be critically thinking about things because maybe this applies to you, maybe it doesn't. I don't know. And then the science continues to evolve. And I just would like women to be more empowered. And here you are empowering yourself with this information. Take it in, talk to your own doctor about it, and then move forward if it's right for you or not. It's my 2 cents. So before I let you go, because I do have more questions, we have to have another part 3 to this, but I would love for people to just please go to the show notes, grab that book, Happy Healthy Hormones. I have the link to that. It's going to be to the 8th edition to that. Go take a look at iobim.org. Find yourself a practitioner, a doctor who's trained in menopause medicine, who knows what they're doing. And that stands for the Institute of Bioidentical Medicine. We've got Dr. David Rosensweet's website and the Facebook all here in the show notes. And I see that you may have a new Facebook group. Is that open? Do you know anything about that? Because I know you also have a lot of people doing things on the side.
It's a good question. I know there's a lot of activity to activate that, and they've told me that that's happening, but
Yeah.
I don't know its current status. And my partners do. They're onto it. There's
Yeah. It's a it's a Facebook group and I just can't remember the name, but I'll get it and I'll put in the link in the show notes. And I just saw, it's like, oh, this is fabulous where all these doctors are talking to each other. And then there's health practitioners and then there's people, just regular people asking the questions. And I think it's a super cool forum. And I encourage people to go look at that, go take that in the show notes. And before I let you go, do you have any events or programs or things coming up that you'd like to share?
well, I mean, I spend my professional life teaching and training, and there is a new thing. There's some national franchises that are offering some terrific prices. And what a woman has got to realize is that there's the hormones themselves, and they cost something. And then there's the licensed healthcare provider that's gone through all the training and education and has an overhead to beat the band. And what hormone therapy really amounts to is both of those. And so there's some new offerings out there, concierge medicine, in which the providers are offering for a single monthly fee, all the consultation time you need and all the 4 ovarian hormones you need. You pay a single monthly fee. And I think that's a wonderful approach because then the women, that first year where there's quite a bit of time needed in some cases to dial in, that they're not concerned about calling once a week or, setting up an appointment once a week or going through a process of daily communication or once every 3 weeks. The taxi meter's not on. So I love those bundles. And this is what's new is these concierge models. And there's a big franchise out there that's doing that. And so
Hmm.
there's several private physicians and nurse practitioners that are doing it as well. So that's another thing to look for. And our people know about it. If you contact IOBIM, they know who these people are and what states they're in. And
Ooh, that's another podcast episode because I think there's several of these popping up and I'd like to break that down a little bit. But another question before I let you go, is there any last words for a woman going through this menopause transition?
well, I've said it so many times. This is for women. This is for men as well. As these hormones are the most powerful biochemicals in our body, and we reach midlife and they're really reduced. And we do well, we thrive, we get to live long and strong based on a lot of factors. We're at risk for a lot of stuff, and you named it, Sora. Right in the middle of this, two-thirds into this podcast, you say, well, what about these other factors? Diet, nutrition, exercise, spiritual growth, emotions, consciousness, they really matter. But on the biological level, replenishing these hormones is one of the most powerful and usually successful things you can possibly do to live long and strong. There's all these other things that really do matter, but become become knowledgeable about hormones too, so that you get yourself in an ideal situation that you're getting these hormones replenished. And when will I stop taking my testosterone, or when should a woman stop taking her hormones? The day I can't open the cap, which may it never come because I'm pretty strong still. Our whole lives, right up, we thrive with this part of what matters to health. Biologically, these hormones are one of the most important things you can do.
Wonderful. We'll end on that note. I can't wait to have you on again. And everyone, please go follow Dr. David Rosensweet, IOBIM. If you need any help, always can reach out to me and I'll connect you. So have a wonderful day, and then we'll see you next time.
Thank you, Zora.